Right upper quadrant pain and fever after MI. Dessert by candlelight in the piazza, some cannoli, some bubbly, and a nice clinical case to review. Let's see here. Alfonso is presenting after holy cannoli, this guy doesn't sound too hot. He's on pressor therapy for days after what sounds like a pretty major MI, and now he's got a new fever and leukocytosis. But heck, seems like the ICU team has pretty much ruled out most causes of fever, but there's one that's jumping out at me. Fever, right upper quadrant pain, and leukocytosis and elevated LFTs? Sure sounds like acute cholecystitis to me. But it might be because I just watched that sketch with the bocce ball match over in the piazza. You can kind of see the court off in the distance. Be sure to check out that sketch on cholelithiasis and cholecystitis if you haven't already. Well, folks, I'm thinking it's a slam dunk of a diagnosis. Sounds like classic science. So, now all we gotta do is check that ultrasound and what the heck? There are no stones in the gallbladder? What's going on here? How can there be cholecystitis without stones? No bocce balls allowed over here, folks. Strict rules. When you've got a patient presenting with the classic signs and symptoms of acute cholecystitis, but there are no stones on the ultrasound, then you ought to be thinking about acute acalculous cholecystitis. The A here means without any calculus, which, of course, means stones. And no math either. Thank you very much. Acalculous cholecystitis is fairly rare, making up about 5 to 10% of all acute cholecystitis cases, and patients are quite a bit different than your average cholecystitis patient. The patients who get this are almost always critically ill with conditions like multi organ failure, severe trauma, recent major surgery, extensive burns, sepsis, shock, and prolonged TPN use. Other risk factors include chronic immunosuppression, severe systemic chronic diseases, especially if they're end stage, systemic conditions affecting perfusion, and non stone mechanical obstructions of the cystic duct. For our clinical case patient Alfonso, he definitely falls into a critically ill category with his continued shock. So, this is the etiology of his cholecystitis and not gallstones, like most cases of acute cholecystitis. And that's the answer to our first clinical case question. So, how exactly does this happen? Oh, is this like a churrascaria? Just the Italian version? Good thing he put the stop sign up, or they'd keep trying to give him food. Like a good Italian nonna. Mangia, mangia, eat, you're looking so thin, eat something. Well, the exact pathogenesis is multifactorial. The main idea is that significant bile stasis due to fasting, since these critically ill patients probably aren't eating, and narcotics, and conditions that impact perfusion to the gallbladder result in gallbladder ischemia, and sometimes reperfusion injury, all of which leads to local inflammation and gallbladder distension, which then worsens the ischemia. Mmm, those cannoli look tasty. And a little bubbly to wash them down? Mmm, stylish. Too bad he couldn't last till the end of the meal. But Prosecco on presser seems like a bad idea. Chianti, much better. This can lead to secondary bacterial infection, gallbladder necrosis, gangrene, and even perforation. Emphysematous cholecystitis is also possible. While these are considered complications, they are commonly present at the time of diagnosis due to delays in diagnosis. Ooh, that looks like an aspiration hazard. Unfortunately, assessment of these patients can be difficult, as many are sedated and intubated due to their critical illness. That's certainly the case with Alfonso from our clinical case. This can significantly delay the diagnosis, allowing those complications to occur. Symptoms are the same as calculous cholecystitis, like right upper quadrant pain and nausea, but the presentation can be very vague. Again, because these patients are often unable to communicate their symptoms. Sometimes there's nothing more to go off of than unexplained fever and leukocytosis. And there are a lot of other conditions that cause leukocytosis and fever, especially in critically ill patients. So you have to remember that acalculous cholecystitis is a possibility. You got the works, huh? No wonder you're not feeling so hot. Food coma is real, friends. A thorough workup may be necessary to exclude other conditions that could be causing the patient's vague clinical findings. So, things that cause fever and leukocytosis with or without right sided pain, like pneumonia or right sided pyelonephritis or subhepatic abscess, is a few examples. They certainly did an extensive workup in our clinical case for Alfonso. Right upper quadrant tenderness may be noted on exam. If they can communicate, Murphy's sign should also be assessed. Alfonso's tenderness is definitely elicited on the clinical case with his grimacing, despite not being able to communicate. Other clues include elevations in LFTs, also present in our clinical case. Unexplained jaundice or a right upper quadrant mass in a critically ill patient should make you think of this diagnosis, but these are rare. Imaging is obviously critical in these patients who can't express their symptoms. So, again, a high index of suspicion is needed to order the imaging. The best initial test is ultrasound, since it's non invasive and portable, which would show all the same findings as calculus cholecystitis, just without any stones. This means gallbladder wall thickening greater than 3 millimeters, gallbladder distension, and pericholocystic fluid. There can be sludge, but no stones. Bingo for Alfonso. Whoa, Alfonso, wake up, dude. Your man purse is getting stolen. And I gotta say, it's really working with that Thieves Ensemble. Bravo, Bandito! If ultrasound is equivocal, the next steps are a CT or HIDA. CT would show the same findings as ultrasound, and HIDA would be positive, meaning you won't see the gallbladder filling with the radioactive tracer. At least he's food coma-ing in major style. The ice bucket is a real classy touch for that Prosecco. It's a shame he won't be able to pay for it. Probably gonna have to wash some dishes. As soon as the diagnosis is confirmed, get that patient started on antibiotics. General supportive care should be started, like making them NPO, controlling pain, and getting them on IV fluids, but a lot of this is likely already happening if they're critically ill. The more important step, however, is immediate intervention. Medical management alone is not appropriate, and delays to intervention increase the risk of severe complications and mortality. The treatment of choice is cholecystectomy. But often, these patients are too unstable for surgery, so a percutaneous cholecystostomy tube can be placed to drain the gallbladder until they are more stable and appropriate candidates for surgery. Development of complications requires emergent surgery. Note for our clinical case patient, he is not an appropriate candidate for surgery, both because he's hemodynamically unstable and because he had a recent MI. So, a cholecystostomy tube for him. And that's the second answer for us. Another creepy dude? Man, thieves and villains be lurking around this piazza right now. I guess it makes sense. People passing out at their tables do seem to make easy targets. I wonder if he's gonna fight the other guy over that purse. I mean, if he's not, I might. I mean, it's really snappy. Satchel, man purse, I don't care. It's functional and it looks good. I'm getting one. Cases of acalculous cholecystitis have a high mortality rate, often due to their critically ill state rather than the gallbladder itself. Complications obviously increase that mortality rate significantly. I don't know about y'all, but I think I need an espresso right now. So how about we wrap this up? Just take a short review, and then we'll leave Alfonso to rest in peace. Not what I meant. I meant slumber peacefully. Anyways, acute acalculous cholecystitis results from bile stasis and decreased perfusion to the gallbladder, which leads to ischemia, local inflammation, and gallbladder distension. Necrosis, gangrene, emphysematous cholecystitis, and perforation are common, reflecting the severity of the condition. Patients tend to be critically ill from any cause, including multi-organ failure, sepsis, shock, severe trauma or burns, and recent major surgery. Prolonged TPN use is also an important risk factor. Other causes include severe and chronic systemic conditions, including immunosuppression. Assessment of these patients can be difficult due to their clinical condition, but this presents similarly to acute calculus cholecystitis, with right upper quadrant pain and nausea as symptoms. Fever, right upper quadrant tenderness, and a positive Murphy's sign on exam and leukocytosis and elevated LFTs on labs. A thorough exam must be performed to identify or rule out other causes of fever, especially in critically ill patients. Ultrasound is the best initial imaging and would show gallbladder wall thickening, a distended gallbladder, and pericholecystic fluid. IV antibiotics and other supportive measures should be initiated, but immediate intervention is the most important step to reduce progression of severe complications. Cholecystectomy is preferred, but most patients aren't appropriate for urgent surgery, so a temporary percutaneous cholecystostomy tube is a common treatment option. What happened? Oh, so full. Hey, waiter, can I get another Botox to go box? Oof. Oof. Wait, what the heck? Where's my wallet? Oh man, not again. I gotta stop food combing at tables. Wait, I didn't know they had prosciutto and carbonara here. Okay, 2 more plates and then I'm going home.